good afternoon, and welcome to all to this today's presentation on acute coronary syndrome. So yes, last lecture, just I have discussed about the overview of the ischemic heart disease, and we all know that acute coronary syndrome, the ischemic heart disease has got two entities. One is acute coronary syndrome, and another is chronic stable angina. So chronic stable angina, we all know that when there is a angina in a stable condition and patient has a chest pain, especially on exertion for a prolonged period, and this chest pain is increasing in intensity day by day, usually when there is a increased amount of atherosclerotic plaque, burden is increasing day by day, and there is increasing obstruction through the coronary artery, and there is a reduced blood flow through the coronary artery that leads to the development of the chronic stable angina. And now today, I will discuss about the acute coronary syndrome. The acute coronary syndrome is acute coronary syndrome. That is, this syndrome is acute in onset, and this syndrome occurs within the coronary artery. So pathology within the coronary artery. So at first, we should know what is the pathology in the during the acute coronary syndrome. What is the pathology during the acute coronary syndrome? So pathology in the acute coronary syndrome is that during acute coronary syndrome usually occurs when there is a totally obstruction of the coronary artery, total or subtotal obstruction of the coronary artery due to any pathology within the coronary artery. It may be due to atherosclerotic plaque, it may be due to embolus, it may be due to thrombus, or it may be due to compression from outside, or it may be due to the severe vasospasm that lead to the actually total obstruction of the total flow of the blood flow through the coronary artery, and there is virtually there is severe obstruction and severe outflow of the obstruction through the coronary artery, and that leads to the severe ischemia to the coronary myocardium, especially myocardial muscle cells, and that led to the even this total obstruction for a prolonged period may lead to the development of the ischemia to the cardiac muscles at the initially, and then subsequently, if this ischemia persists, then the cardiac muscles may die, or this dying condition is called infarctions. So, since this acute, what is the pathology of the acute in the acute coronary syndrome? So, pathology in the acute coronary syndrome, just I repeat, as there is obstruction and there is severe obstruction, this obstruction may be due to the atherosclerotic plaque burden, there is severe atherosclerosis, or that may be due to a thrombus, or that may be due to the embolism, or that may be due to the severe coronary vasospasm, and that lead to the total or subtotal obstruction of the blood flow through the coronary vessels, and that is severe ischemia to the cardiac muscles, and that led to the development of the at first ischemia to the cardiac muscles, and subsequently there is a destruction, or there is the infarction of the myocardial cells. So actually this is the pathophysiology or pathology during the acute coronary syndrome. Even this acute coronary syndrome may occur on the top of the chronic stable angina. If a patient have coronary atherosclerosis in the coronary artery, and there is a acute, there is a total or subtotal obstruction of the coronary arteries due to the atherosclerotic plaque, and if there is any rupture of the atherosclerotic plaque, if there is any rupture or crack within the atherosclerotic plaque, there is a through this collagen fibers in the atherosclerotic plaque is exposed to the contents of the blood, like platelets and other coagulable factors that lead to the development of the formation of the thrombus within the overlying atherosclerotic plaque, and this atherosclerotic plaque then causes total or subtotal obstruction of the coronary arteries, and that lead to the development of the acute coronary syndrome. So acute coronary syndrome may occur suddenly without any chronic stable angina, or acute coronary syndrome may occur on the top of the chronic stable angina if a patient suffering from chronic stable angina for a prolonged period and there is a rupture of the atherosclerotic plaque. So this is the actually pathophysiology. So how the acute coronary syndrome patients usually present. As we know that acute coronary syndrome includes the three entities. One is unstable angina, and the another is non-ST elevated MI, and the another is ST elevation MI. So unstable angina, non-ST elevated MI, and ST elevated MI. So this entity is actually divided on the basis of the ECG changes, one, and the other factors is depending on the rise of some cardiac enzymes like CKMB or troponin I. And if there is a ECG changes like this, if there is a ST elevation on with acute coronary syndrome, that is a patient suffering from acute coronary syndrome, and there is a ST elevation, then it is called ST elevated myocardial infarction. And usually in that cases, if this ST elevation is persistent and there is a damage of the myocardium that leads to the increase in the cardiac troponin I level or CKMB level, there is significant increase of the cardiac troponin I or CKMB level that usually leads to the development of the ST elevated MI. So ST elevated MI includes there is a ST elevation, there is persistent ST elevation in the any leads of the ECG, especially that corresponds to the area of damage, especially it may be in the antral lead ST elevation, it may be in the inferior lead ST elevation, it may be in the lateral lead ST elevation, or it may be the antral lead as the lateral lead that may lead to the extensive anterior myocardial infarction, we call it. So there is a ST elevation in the different leads, as well as there is a increase, significant increase of cardiac enzymes like cardiac troponin I and or CKMB. And so these are the inclusion criteria of the ST elevated MI. So what is the non-ST elevated MI? In non-ST elevated MI, usually the ECG changes, so there is no ST elevation. Instead of ST elevation, there is a ST depression or there is T inversion. Is ST inversion, ST depression or T inversion changes, or even ECG may be normal, even still ECG may be normal also, but there is increase in the cardiac enzymes like troponin I or CKMB, and it must be significant increase of the troponin I or CKMB, usually in that cases that lead to the development of the non-ST elevated MI. That is, there is no ST elevation, but there is maybe ECG changes or without any ECG changes. That ECG changes includes there is a ST depression or there is a T inversion, usually in the non-ST elevated MI. But the mandatory criteria is there is should be significant increase of enzymes, cardiac enzymes, especially like cardiac troponin I. Cardiac troponin T also may be usually in Bangladesh usually measure cardiac troponin I or CKMB. We can also measure CKMB. So either significant rise of the CKMB or significant rise of the troponin I, along with there are some ECG changes like ST changes that usually the characteristics of the non-ST elevated MI. So what are the characteristics of the unstable angina? So when we consider ECG changes, the unstable angina may have normal ECG or there may be some ST depression or there may be some T inversion in ECG changes, but in that cases, usually this patient because cardiac enzymes may be normal or there may be mildly elevated. But all these patients, these are in the acute coronary syndrome, that is a patient with unstable angina or patient with ST elevated MI or patient with non-ST elevated MI, how usually this patient presents? Usually this patient presents with chest pain on rest, usually rest, chest pain in the rest, usually this is the characteristic features of the acute coronary syndrome. So how we can differentiate clinically from acute coronary syndrome to the chronic stable angina? So a patient with chronic stable angina, usually they experience chest pain or chest discomfort when on exertion. That is when patient is in the with some there is some load on the cardiac muscles. There usually patient when there is patient is running or patient is walking or patient getting upstairs. Usually they experience chest discomfort. Usually on especially on exertion. So on exertion, if patient gets chest discomfort, then it is usually features of chronic stable angina. And if a patient gets chest discomfort, even in the when the patient is in the rest, that patient is the rest, then actually this is called acute coronary syndrome. But what are the characteristics of pain? A patient with acute coronary syndrome or chronic stable angina, there should be some characteristic pain. If a patient has chest pain, and I already discussed in the earlier or previous lecture that chest pain and angina are not synonymous. All anginas are the causes of chest pains, but there are a lot of causes other than angina that may causes the chest pain. So there may be a lot of causes. That may be respiratory causes, there may be lung causes, there may be pleural causes, there may be pericardial causes, there may be esophageal causes, there may be liver causes, there may be gallbladder causes, there may be stomach causes, there may be causes in the pancreas, or there may be reflux esophagitis. There are actually a lot of causes. Even the pathology may lie in the skin or overlying the chest, or there may be pathology in the muscles, or there may be pathology in the ribs also. So there are a lot of causes of chest pain, but a patient having chest pain may not due to angina. But if a patient has angina, that means the chest pain is usually due to the pathology in the this heart. Among this pathology in the heart is lead to the causes of chest pain. Usually it may be due to the acute coronary, it may be that there is pathology in the coronary arteries, or there may be pathology outside the coronary arteries. So this is a coronary artery disease, or there may be other causes that may lead to the actually angina. Usually we call angina, especially there is a coronary artery disease, or there is a pathology in the muscles, especially there may be hypertrophy of the cardiac muscles. Usually there is a, we call it demand supply mismatch. So there may be increased demand, or there may be increased, there may be reduced supply. If there may be reduced supply through the coronary arteries, there may be obstruction. Usually that may lead to the angina. Or if there is a increased demand, like there is cardiac muscle hypertrophy, as we have seen in left ventricular hypertrophy due to aortic stenosis, or we have frequently seen a patient having hypertension, that may, uncontrolled hypertension especially, that may lead to the left ventricular hypertrophy, or right ventricular, or any pathology may lead to the right ventricular hypertrophy also. Not only left ventricular hypertrophy, right ventricular hypertrophy also causes maybe have angina due to increased demand, but blood supply through the coronary artery may be normal. So if there is a supply demand mismatch, so that may lead to the actually development of the angina, that is called, we call it angina. So a patient having angina, and this angina, we have already discussed, this angina may be stable, that is the patient have chest pain only on exertion, and usually when patient takes rest, the angina relieves. So, or the angina is relieved by taking sublingual nitrates. This is the characteristics of the chronic stable angina. So if we summarize the characteristics of the angina, chronic stable angina, the characteristics are like that. Usually this chest pain is on the central in position, usually substernal. That is, the pain is behind the sternum. And this is actually, it may be in stabbing in nature, it may be in the choking in nature, or it may be, the exact nature is usually, this is compressive in nature. That is, patient usually experience, there is a severe compression over the chest. Usually they experience, there is also the patient expressed in the way that there is a heaviness over the chest. So the chest pain is like that. There is a substernal chest pain, usually central in location, and this has got some radiation characteristics like this pain is usually radiated through the left arm and the or ulnar side of the left forearm, even on the little on the along the little finger also. So this patient is substernal chest pain or compressive in nature usually, and it radiates usually on the left upper limb usually along with the left arm, then left forearm, and along with the left little finger. Usually this this how the pain usually or due to angina, in chronic stable angina, this is how it radiates. This actually this patient experiences this type of substernal compression usually on exertion. Patient on exertion, especially after taking meal, when patient walks or taking upstairs, or patient is in the on any type of exertion. Actually, patient experience this type of chest discomfort usually in the chronic stable angina. So these other characters are what actually increases this type of chest discomfort. When patient on exertion, usually this chest pain increases. And how it can be relieved, this chest pain, usually this chest pain is relieved by taking sublingual nitrates, or when patient taking rest. Actually when patient is walking or patient is running, and patient just when he or she experiences discomfort, and then he or she stops and taking some rest, usually this patient subsides. Again, when patient taking having exertions, this usually this type of chest discomfort returns. So actually, this is the way how the patient with chronic stable angina patient experiences this chest discomfort or chest angina, how it experiences actually this way. And how actually acute coronary syndrome patients experience chest discomfort when the patient is usually even the patient is in the when he's sleeping, just he may be awake from sleeping due to severe chest discomfort along with sweating. That patient may have also vomiting, and there is a severe sweating, there is a severe central chest discomfort, and this usually chest discomfort may radiate through the left arm or right arm, or this discomfort may radiate upwards in the throat, or this discomfort may radiate backwards also between the two shoulder blades. So this chest pain may, even this chest discomfort may be experienced as peptic ulcer disease-like presentation, like there is upper abdominal discomfort, patient may experience vomiting, even the patient may experience actually these sorts of chest discomfort a patient may experience in case of acute coronary syndrome. So in acute coronary syndrome, our patient even when he's sitting, or the patient maybe is lying, usually the patient experience this type of chest discomfort, and all on a sudden, actually this patient may experience this type of chest discomfort. This is rotational chest discomfort. This is compressing in nature. This has got some radiations, and this may be associated with excessive sweating, and the patient may be with nausea or vomiting, and may be associated with this chest discomfort. Even this chest pain may not be relieved by taking sublingual nitrates, may not relieve it, and this chest discomfort may persist more than 30 minutes, even with sublingual nitrates and taking rest. Actually, this as this pain and exerts or pain starts even in the patient when in the rest. So rest has got no impact on the relieving of the chest discomfort. So actually, this is the way actually a patient with acute coronary syndrome usually presents. So acute coronary syndrome patient may present with chest discomfort, rotational chest pain, severe chest pain. That patient experience that he's dying. Patient may just talk like this, that I am dying from this chest discomfort, or his feeling is like that, I am dying. So this is the rotational chest discomfort. And the patient having along with chest discomfort, there is some radiations, and patient having abdominal discomfort or nausea, vomiting, and with excessive sweating. This undue sweating patient may usually experience. So this is the pain and how this patient, even in patient with acute coronary syndrome, along with chest pain, if the patient has got some complications like heart failure, then patient may experience with along with chest pain, he experienced severe breathlessness as there is acute left ventricular, maybe acute left ventricular failure. If there is a massive cardiac muscle damage and there is a reduced in the cardiac output, so patient may experience of acute left ventricular failure. Even patient may with hypotension, there's low blood pressure, that is called cardiogenic shock. If there is a blood pressure, there is a lot of cardiac muscles involved, and there is a cardiac muscles damage is more, then the patient may have a low blood pressure, and this patient is designated as a cardiogenic shock. And this, if the patient develop cardiogenic shock, this has got actually high mortality in a patient with acute coronary syndrome. And even this patient may present with other complications, like patient may present with the features of heart block, or patient may present with features of arrhythmia, like ventricular tachycardia, supraventricular tachycardia, or ventricular fibrillation, or even patient may have sudden cardiac death, may present with sudden cardiac death also due to any development of any type of fatal arrhythmia like VTVF and SVT. This type of fatal arrhythmia, patient may present with sudden cardiac death also. So actually, this is the way of presentation of a patient with acute coronary syndrome. So, so this is the actually presentation, and how usually we diagnose a patient with acute coronary syndrome. When patient comes with chest pain, with sweating, and usually this patient may come into the emergency department at any time. Patient may present with at night or at midnight. Patient may present with at early morning, or patient may present with in the evening, or patient may present with at night. Anytime patient may present with this sort of chest discomfort in the emergency department. When they present in the emergency department, actually then we take some history also. The what history we should stress to take from the patient. Usually at first, when patient comes, we want to differentiate the causes of this chest pain actually. So we advise our in emergency department, our sister that please sister do ECG immediately to this patient. And actually in emergency department, every bed has got some monitoring. So there is a patient is monitored by ECG leads. And also at 12-lead ECG was done. And during ECG, during ECG doing, actually, then at this time, actually, we get some history. The details of the chest discomfort or chest pain. We also take history of the some risk factors also that can lead to the development of this myocardial infarction by acute coronary syndrome. Usually patient when present with acute coronary syndrome, usually we seen that patient has got usually 1 or 2 or 3 maybe risk factors usually they have, like patient may be smoker, patient may be chain smoker, or patient may be ex-smoker, or patient may present with diabetes, maybe uncontrolled diabetes. Usually a patient when they have history of diabetes, and we usually do reflow in the emergency department. Invariably, we see that patient actually his blood sugar are unstable, or blood sugar are not controlled. They have uncontrolled diabetes mellitus. Even they have blood sugar more than 15 or 20 millimole per liter. So in the maximum cases, usually we find that his sugar level is uncontrolled. So we should also take care of the blood sugar of this patient. Because if we don't take care of this blood sugar, if we don't control the blood sugar level, usually this patient, acute coronary syndrome patient, has got grave complications or grave outcome. The outcome is bad if the patient's blood sugar is not controlled. So this patient has got good blood pressure control when he's staying in the CCU especially. So his risk factor number is smoking due to diabetes mellitus, And in some cases, we see that this patient has got raised blood pressure, that is, patient has got hypertension. And in some cases, even they don't know that they have hypertension. And hypertension is a silent killer. We all know that this patient may have hypertension, even patient doesn't know it. Or this patient has usually, when they know that they have hypertension, but sometimes times that they usually don't taking medicine or antihypertensive drug regularly, so their hypertension may be uncontrolled in some cases. So we always see that usually this patient has got uncontrolled hypertension also. And when the patient admitted in the CCU usually send some investigations to see one, to confirm the diagnosis of the acute coronary syndrome, also to send some investigations to see some risk factors and what are the condition of the risk factors usually they have. Yeah, so we send blood sugar, and we also send the lipid profile. In some cases, we will see that they have, if they have uncontrolled diabetes, even they have raised triglyceride level, or even may have total cholesterol level may be raised, or they may have reduced HDL level or low HDL level. That may be a risk factor for coronary artery disease, or that may be risk factor for coronary syndrome. So actually, these are the risk factor history usually we are taking. Even we also take the family history if there is a strong family history of this patient. So we take family history of the ischemic heart disease or hypertension or diabetes mellitus, so of this patient. So usually we are searching this risk factors analysis along with doing ECG. Usually, what are the findings? Usually, we will get a patient having acute coronary syndrome. What are the ECG findings? Usually, we get. I have already discussed, but for your better understanding, I just repeated that this patient usually have this patient in acute coronary syndrome setting. This patient may have normal ECG. Just mind it. The patient even have normal ECG. That patient may have unstable angina with normal ECG. Even there may be some STT changes. That is, this patient may have hyperacute T. That is, tall T waves you may get in the hyperacute. That early part of the mitral infarction you may get that is tall T waves, or you may get T inversion, or you may get ST depression or T inversion. So these are the ECG findings. Even we may get ST elevation also. So when the patient has ST elevation, usually we designated this patient as ST elevation MI. If this patient and we will send actually along with lipid profile, blood sugar, and along with usually send this patient for biochemical investigation, the cardiac troponin or CKMB usually we will send. Invariably, actually, the serum troponin I or serum CKMB level, we usually find the raised or elevated in case of ST elevated MI or non-ST elevated MI. But in case of unstable angina, there may be slight elevation, or there may be normal in case of unstable angina. In case of unstable angina, there may be ECG may be normal, there may be enzyme may be normal. But some cases, there may be enzyme normal, there may be some ECG changes. And in some cases, there may be ECG normal, there may be some degree of enzyme level that is increased, but not so much increase, in case of unstable angina. But in non-stable MI, there may be ECG normal, there may be ECG abnormality like ST depression or T inversion, but their enzyme is usually raised or must be raised. And in case of ST elevated MI, there is a ST elevation, as well as there is the cardiac markers or cardiac enzymes is really elevated and usually highly elevated in case of ST elevated MI. So these are the actually enzyme findings, and these are the actually ECG findings. Usually we actually get in an emergency department or even in the CCU of a patient with acute coronary syndrome. So when a patient comes with acute coronary syndrome, after diagnosis of acute coronary syndrome and confirming the diagnosis, usually we send the patient to the CCU for admission. And in the CCU, when patient comes to the CCU, what are the actually investigations and what are the treatment facilities or treatment modalities usually we offer to a patient with having acute coronary syndrome. So what are the investigations? I have already discussed that patient to see the condition of the risk factors like diabetes mellitus, so we see blood sugar level and even hemoglobin A1C. And for seeing the condition of the lipid profile, we will see lipid condition of the patient, so we will see serum lipid profile. And to see confirming the diagnosis of the acute coronary syndrome, usually we see serum troponin I, or we'll send for our CKMB. Usually after 4 hours of the initiation of the chest pain or starting of the chest pain, usually after 4 hours we should send this biochemical marker, that is CKMB or troponin I should be sent. Even if we send this troponin I or CKMB before 4 hours, so as there is due to damage of the cardiac muscles, usually these enzymes are released from the cardiomyocyte into the circulation. So to diagnosis or to confirmation or to increase a certain level or to achieve a certain level of this enzyme, it usually takes 4 hours. So if we send this biochemical marker, that's troponin I, CKMB before 4 hours, it may be false negative. So we should be cautious about the timing of the sending this actually troponin I and or CKMB level to send for biochemical analysis. So we should be cautious about the timing from the onset of the chest pain. We should always ask the patient when his pain actually starts or the chest pain actually starts. So we have to record the time of this chest pain so that we can correctly send in the time of the sending the or CKMB or serum troponin I level, and we can get the correct result actually. So this is the investigations, and when patient comes, usually we to relieve the chest pain. As chest pain is ongoing, and if the patient experiences severe chest pain, patient may develop heart failure or patient may develop arrhythmia or fatal arrhythmia. So to avoid the fatal arrhythmia or to the patient is suffering from the heart failure, usually we giving morphine or pethidine to relieve the chest pain immediately to the patient. So before actually doing any other treatments or to starting the definitive treatment, actually at first what we should do to a patient coming with acute coronary syndrome, usually we should do at first, usually we should take initiative to relieve the chest pain of the patient. And for to relieve the chest pain of the patient, usually we give morphine or pethidine and to the patient to alleviate or to relieve the chest pain. And what are the actually then actually we will start other things. Even ECG may be repeated, or if patient is having acute coronary syndrome. So depending on the type of acute coronary syndrome diagnosed, our treatment varies. So and there may be some standard protocol of the acute coronary syndrome. There may be usually we'll give this sorts of drugs and some that is called anti-ischemic drugs to all the patients, irrespective of the type of acute coronary syndrome. And depending on the specific type of acute coronary syndrome, then actually we select the different types of definite treatment. But for all patients, for having acute coronary syndrome, this patient may have an unstable angina or long-stability MI or stability MI. This patient should get antiplatelet drugs. Especially patient should get ecosprin or clopidogrel. Usually we will give loading dose, that is 4 clopidogrel and 4 ecosprin or 300 milligram ecosprin and 300 milligram clopidogrel. Usually we given as antiplatelets to the patient as a loading dose, and the other drugs are usually we will giving beta blocker if there is no contraindication, if there is no bronchial asthma, if the blood pressure is above, that is patient is stable and his systolic blood pressure is more than 100, or patient pulse rate is more than 60, or if the patient has got no contraindications, so usually we'll give this patient to the beta blocker. Usually we give nitrates to give relieve the chest pain. And in case of maybe sublingual nitrates or maybe oral nitrates, or if patient may need IV nitrates also. So if patient has, but this patient should have a stable condition. That is, his blood pressure should be stable. So we'll give nitrates, we'll give beta blockers, and actually we'll give high dose statin to the patient. It may be give atorvastatin 80 milligram, or rosuvastatin maybe 40 milligram or 20 milligram. We actually should give to the patient having acute coronary syndrome. So, and this hydrostatin has got some role, that is, this usually this high dose atorvastatin or high dose rosuvastatin, that is high dose statin, and they have a role of that is this plaque stabilization. Usually, I have already discussed the pathogenesis of acute coronary syndrome. As there is a atherosclerotic plaque and there is a rupture of the atherosclerotic plaque, there may be some superimposed thrombus accumulation and ultimately occlusion of the total coronary vessels. So if we stabilize the plaque, this plaque stabilization, and usually this is the good healing of the plaque, and there may be further propagation of the thrombus may occur. And so if we give hydrostatin, if there is a plaque stabilization, so this propagation of the thrombus formation may be inhibited. So there is improvement of the coronary circulation to the patient, and so there is increased oxygen and blood supply to the cardiac muscles. So plaque stabilization is an important factor in case of acute coronary syndrome. So for plaque stabilization, usually we add high dose statin like atorvastatin or rosuvastatin. So these are the one treatment usually we should offer to the patient. And these are what are the usually other treatment. If the patient has got heart failure, then actually in that cases we may add ACE inhibitor by ARB, or the patient has got proteinuria, or this if the patient has got diabetes mellitus, we may give the ACE inhibitor ARB. Or if the patient is hypertensive, uncontrolled hypertensive, then in that cases we should choose some antihypertensive also to control the blood pressure. In that cases, IV nitrates may also role some play to control the to reduce the blood pressure, to control the hypertension also. So these are the actually drugs, standard care of drugs to all patients of acute coronary syndrome we should give. And what are the specific treatment if a patient has got unstable angina or acute stabilization MI or non-stabilization MI. If the patient has unstable angina or non-stabilized MI, in that cases, usually as the pathology or pathogenesis is, there is propagation of the thrombus and there is a subtotal occlusion, and this thrombus is usually fibrin wrist, or usually these are the increased chance of thrombus formation. There is an increased thrombus formation propensity. So usually we choose what types of drugs. In case of anticoagulants, usually we choose that is enoxaparin or dalteparin, low molecular heparin, or heparin, unfractionated heparin, IV heparin, unfractionated, or subcutaneous, subcutaneous low molecular heparin like dalteparin or enoxaparin. We must choose to give and to stop the or to prevent the propagation of the thrombus. So in case of unstable angina or non-stability MI, so our drug of choice or our compelling drug is low molecular heparin or unfractionated heparin. So we have to choose which one is better. If a patient has chronic renal failure or along with mitral infarction, in that cases, usually we may have to choose unfractionated heparin. So there is some specific indication for unfractionated heparin, but without a specific indication or complaint, usually we choose low molecular heparin subcutaneously. So this is the specific treatment for unstable angina or acute coronary or non-ST elevated MI of acute coronary syndrome. If a patient present with ST elevated MI, so along with other standard treatment, what is the gold standard treatment of acute coronary syndrome, that is ST elevated MI. So there is a ST elevated MI, and there is a thorough there is a occlusion of the coronary artery, there is a complete occlusion of the coronary artery. Usually, in that cases, usually we choose the thrombolytics, that is to dissolve the thrombus or to break down the thrombus. So to break or to make a hole within the actually occluding thrombus. So in that cases, we usually choose thrombolytics if primary PCI are not available. So in a patient with ST elevated MI, we have two armamentarium. So we have two mode of treatment. One is the primary PCI, and the other is the thrombolytics. So there are a lot of thrombolytics is available now, and the price is ranging from 3,000 to 4,000 to the even 60 or 70, 80,000 Dhaka. There is a different types of and different qualities of thrombolytics are available, and in some recent thrombolytics are also available in our country. So we should choose accordingly to the actually to the patient's conditions, as economic condition as well as actually patient's physical or other conditions. So there are a lot of thrombolytics available. And the other treatment modalities is primary PCI. So if there is a cath lab available, and in our some centers in Bangladesh, usually we do primary PCI if patient has a ST elevated MI. So if a patient has a ST elevated MI, after taking proper consent, usually we send the patient to the cath lab, and usually we do angiogram, and angiogram findings usually see that there is 100% occlusion or severe occlusion or total occlusion of a culprit vessel, or usually one or two vessels. Usually there is 100% occlusion. And if there is a large thrombus within the coronary artery, usually we have there is a suction catheter, and with suction catheter we do sucked out of this thrombus, large thrombus. But if there is a small thrombus, in that cases, usually we do primary, that is we do there is a balloon angioplasty followed by there is a stenting. Usually we did it, and if there is a large thrombus burden or there is a thrombus, in case of the glycoprotein 2A, 3A inhibitor, usually we may choose in that cases. So there are these are the actually models of treatment of a case of patient with non-ST elevated MI in acute coronary syndrome. So actually, these are the actually presentations, diagnosis, and treatment of a case of acute coronary syndrome. And if I summarize the acute coronary syndrome within very short, that is a patient with acute coronary syndrome usually present with chest pain. This is central in nature. This is substernal, and it has got some radiations, and it may be associated with severe vomiting or nausea, or patient may present with excessive sweating also. And in the emergency department and doing ECG, usually we did ECG, and we send for a cardiac troponin I or some cardiac markers like cardiac troponin I, CKMB, usually after the initiation or after starting of the 4 hours after the starting of the chest pain. And if this, according to the enzyme levels and according to the ST elevation or not, usually we divided the acute coronary syndrome in the 3 groups: unstable angina, non-ST elevated, and ST elevated. So according to the mode of treatment, and usually we give some specific, we have some specific treatment in case of unstable angina and non-steroidal MI, along with other standard medical treatment. Usually we give anticoagulants. These anticoagulants may be unfractured heparin or low molecular heparin. In case of ST-inhibited MI, in that cases we have to have specific, along with other standard medical therapy, we have two options. One is thrombolytics, and the other is primary PCI. So depending on the availability of the cath lab and primary PCI, usually primary PCI is the gold standard treatment for the patient with acute ST-inhibited MI. But if the cath lab is not available or primary PCI facility is not available, in that cases, usually we have the option of thrombolytics. So I think this is the lectures of the acute coronary syndrome today, and I think you have understood it very clearly. If you had attention properly to this lecture. So thank you all. So you have any from Genesis Online Lectures? I'll just stop sharing. So I think no one from is available with me now from Genesis Online Lecture. So I think the next lectures will be on the chronic stable angina in details. That is how chronic stable angina patient presents, how we'll diagnosis, and how this patient should be treated in the next class. We discussed about the chronic stable angina. So thank you very much for patient sharing, and Allah Hafiz.